closely on vaccinations and the genders, examining inequities in gender access and handling of vaccinations globally to inform pharmacy policy. So a very, very warm welcome to all our attendees today. My name is Nadia Bukhari, Associate Professor at UCL, Chief Pharmacist and Gender Lead at Doctors, which is based in Pakistan, and also the FIP Global Lead for WDG 10, Equity and Equality. And with me, co-moderating the session today is my colleague, who I'll hand over to now, Carleen.
Hi, and I'm Carleen McMall, and I'm a pharmacist that works in the pharmaceutical industry, and I'm also a global lead for the FIP for the Working Group Development Group 10, Equity and Equality. So just to let you know that this webinar is being recorded and it's being live streamed via YouTube. The recording will be available on the website, events.fip.org. You may ask questions using the question box provided, and you're welcome to provide feedback to webinars@fip.org. And you're also welcome to become a member of the FIP at fip.org/membership registration.
We're very excited because today we have a panel of three very esteemed colleagues and speakers who will be contributing to the discussions today. And I think without further ado, we'll start with our first speaker and the first presentation.
Right. So I'd like to introduce Dr. Samiratu Odrago. So she is a co-founder and chair of the Women in Global Health Francophone West Africa chapter. So WGH is an organization built on a global movement with the largest network of women and allies working to challenge power and privilege for gender equity in health. It was started in 2015, and the movement has grown to include over 50,000 supporters in 90 countries and has 25 official chapters with a strong presence in LMICS. Dr. Odrago's specific interests include health system improvement, infectious diseases, cancers, sexual and reproductive health and rights, and she has built capacities in the design, implementation, and the evaluation of public health interventions. Throughout her academic and work experiences, she's provided leadership and technical assistance on diverse projects in sub-Saharan Africa, France, the United Kingdom, and Canada, and her work has always been orientated towards health equity and social justice. Dr. Odrago is a member of the Gavi CSO board constituency, and she will be co-chairing the OR Tambo Africa Research Chair in Research and Action Against Cancer at the University Joseph Keko Zerbu in Burkina Faso. So I'd like to pass on to the doctor for her presentation. Thank you.
Thank you very much, Carleen. So hello, everyone. As Carleen said, my name is Samiratu Odrago. I'm a researcher and consultant in population and global health. And I would like to thank the International Pharmaceutical Federation for giving me the opportunity to contribute to this panel discussion. I'm currently based in Burkina Faso, where I have co-founded many local and regional NGOs, including Women in Global Health Francophone West Africa chapter, and I'm currently leading this movement. Slide 2. As Carleen said, Women in Global Health has grown to include over 50,000 supporters in 19 countries, and we now have 27 official chapters with a strong presence in low and middle income countries. Slides. The global network of Women in Global Health chapter drive change by mobilizing a diverse group of leaders and emerging women leaders in health. And we advocate to existing global health leaders to commit to transform their own institutions and hold them accountable. Slides. The government of France and the World Health Organization, in collaboration with Women in Global Health, have set this year, the 2021, the International Year of Healthcare Worker. We want to have a gender equal health and care for initiative. So the initiative aims to increase visibility, dialogue, and also to commit to action on gender equity in the health and care workforce alongside the UN women. Slide. The pandemic has shown us that we rely really on the frontline worker. The majority of these workers are women, and they put themselves in harm's way. Many of them work without adequate personal protective equipment. And we know that available data shows that women are 70% of the global health workforce in frontline of COVID-19 response. For example, in China, Hubei province, where the virus originated, women represent 90% of health workers. And they perform 75% of unpaid and unpaid care work globally. So they work 3 times more than men on childcare, for example, to collect water and cleaning. And women often hold the main responsibility of care for patients who have been discharged, for example, from hospital early and placed in quarantine during this COVID-19. Slides. The data shows that among the healthcare workers, women are more likely to be affected due to many reasons. For example, they have inadequate or they even are not being trained, and they have improper safety equipment. Slides. In terms of leadership, women just hold 75% of leadership roles. And data from sub-Saharan Africa even shows that it's less than 10% that women that have leadership roles. And this happened more than 25 years after the agreement at the Beijing meeting, highlighting the necessity to remove a systematic barrier that hold women back from equal participation in all areas of public and private life. Slides. We need really a gender transformative health system sensitive to differences, because disease prevention strategies in general, and specifically vaccine delivery and logistic planning, must be based on context-specific knowledge of women, men, and gender-driven groups in general, health-seeking behavior, addressing their mobility challenges to access vaccine sites, as well as their preferred channels and source of trusted health information. For example, women will face many obstacles: financially, mobility, stigma, information barriers, time to access vaccine. And in the case of COVID-19 vaccine, confusion on guidance, for example, for pregnant women. We see that in all countries where vaccines are available and free for everyone, even pregnant women, but they are receiving contradictory advices even from medical providers. In rural area, particularly, for example, some women have limited access to information and new source of, and therefore they don't even know, they know even little about the vaccine, which can give rise to misinformation, to myth and misconception, and make them hesitant to get vaccinated when they can. And there are also fear linked to the rise of domestic gender violence during the pandemic. But for example, a woman who gets vaccinated before her husband, who is the head of house, may face abuse and persecutions. We know that men and women have different efficacy reactions to vaccines. And vaccines and medicine have been typically clinically trialed on men. And part of the confusion and hesitancy on COVID-19 vaccine is that they are not really trialed for pregnant women, for example. And vaccine hesitancy is very complex and often higher among women with COVID related to misinformation about fertility, for example. But men are hard to reach, a group of population that are hard to reach, especially because they have little contact with healthcare system. And if men don't get vaccinated, women and children remain at greater risk to be infected. And we are all in this together. And we sometimes forget that women are not only health system users, but they are also drivers of health system for everyone, because women play a critical role in delivery of vaccine, and many of them are in front line, underpaid or even not paid, and sometimes community health care workers are women. Those women need to be engaged in decision making on vaccine campaigns, because they are not right now engaged in this vaccine delivery. They will know best how to engage with the community. So we need employing women vaccinators, for example, is key, along with ensuring safe and inclusive work environment for them. Because, for example, women vaccinators covering remote or humanitarian settings are at serious risk and can face abuse and violence. We cannot also ignore that the potential risk of sexual exploitation arising from imbalance of power between those who are involved in vaccine delivery and those who are in need. It happened during the Ebola pandemic, a vaccination program in Democratic Republic of Congo in 2018, where some male healthcare workers offered vaccine in exchange of sexual favor for women and girls. Many vaccination campaigns in the past are focused on reaching children via women. And this COVID-19 vaccine focus on adults. Women vaccinators are at far greater risk, going door to door vaccinated adult men. And in addition to the positive role they play in the health system, they also play a positive role in community as trusted source of advice. They run community organization. Grassroots women movement are important in addressing vaccine hesitancy and increasing equity in access to vaccine and testing. In some countries like Rwanda, for example, in Africa, women drive change as parliamentarians. It is well established that where there is a critical mass of parliamentarian women, they will drive greater political priority and resources for health. But globally, unfortunately, only 24% parliamentarians are women, and less than 10% in many sub-Saharan Africa, like in Burkina Faso. And we are all losing when women are not in minority in decision making. Slide. An assessment of the availability of data in countries where we have 90% of confirmed cases of COVID-19 show that the sex disaggregated data are far from what is expected. And yet, at a minimum, all countries should collect and report the data on COVID-19 cases, death, vaccination, access to vaccination, broken down by sex. Slide. What can we do as an important politician to reduce vaccine inequity? It's essential, for example, to report vaccination access data, breaking down the impact of accessibility against the target for countries to vaccinate their at-risk population first, to reduce mortality and protect also the health system, and also move to vaccinating the larger set of population to reduce the disease burden and to reopen the economic activity. Slide. Disaggregated data shows data allow monitoring equity in COVID-19 response, including vaccines and testing. Slides. The sex, gender, and COVID-19 health policy portal offer the most comprehensive review of recognition of and the response to sex and gender in national COVID-19 health policies. The portal, for example, finds little evidence that sex and gender have been considered in policy, but directly impact people's health outcomes. Slides. There are key enablers in health policies that could help reduce vaccination inequities, including equity-informed COVID-19 response financing model, a health system and governance framework with multi-sectoral collaborative strategy to access vaccination, and also a governance mechanism that strengthens the linkage between policymakers, civil society, non-governmental organization, community-based organization, and private sector in general. Slides. As a health service provider and also community partners, pharmacists could contribute to reduce vaccination inequity. For example, they can organize communication campaigns to inform the community on immunization and the importance of being immunized. And they can also guide the community toward useful resources and information. Therefore, they can also, for example, offer support at vaccine sites, for example, transportation, publicity. They can organize themselves vaccination events for their communities. Also report data and inform health authorities on any issue related to vaccines, like inequities, marginalization, side effects, hesitancy, coverage in general, etc. There are many factors, there are many ways that they contribute to reduce this vaccine inequality. We must change the vaccine inequity by including all gender and socioeconomic voices in the conversations around vaccines delivery, acceptability, and hesitancy. Thank you very much for your attention.
Thank you so much for that, Dr. Samira Ouedraogo. That was such an empowering presentation. And my sort of key message from there, really, from one of your slides, was that women are on the front lines fighting the coronavirus. That's very sort of empowering in itself, that statement. So thank you very much. We will be taking questions right at the end. So once all our three panelists have spoken, then we will take the Q&A. So I'm seeing quite a few coming through now. So please do feel free to submit your questions within the Q&A box. So moving on to our next panelist, Erica Rosa. Erica Rosa MHS is a research associate in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. She has extensive multidisciplinary research experience and has spent more than 10 years providing technical support to and leading research projects across a range of methodologies, i.e. monitoring and evaluation, formative, ethnographic, academic, and field research, and technical areas, for example, infectious diseases, gender, child survival, women's reproductive health, HIV, nutrition services, health systems, capacity building for public health projects in the USA, Africa, Latin America, Asia, and Europe. She has also demonstrated history of project management and effective collaboration with national institutions and by multilateral organizations. For the past year, she has served as a core member of an international team working on the award-winning Gender and COVID-19 project to identify and document the gender dynamics of the COVID-19 pandemic and provide real-time policy guidance and recommendations at the global and national level. So a very warm welcome to you, Erica.
Thank you for that introduction. I'm really happy to be here today.
Thank you. Take it away.
Slide. Okay. So I'd like to talk about why gender is relevant to how we think about and manage pandemics, including COVID-19. Slide. Pandemics are gendered. When we look at who makes the decisions, who suffers from the primary and secondary impacts, we can see gender imbalances across all these categories. And it's only by recognizing the differential effects that we can effectively manage how the negative impacts of pandemics are experienced by disadvantaged groups and also improve our efforts in pandemic control and recovery. Slide. We already know from studying past epidemics like Zika in Latin America and the Caribbean, Ebola in West Africa and the Democratic Republic of Congo, and SARS in Asia, that the secondary effects of these outbreaks, like limited sexual and reproductive health services, fell disproportionately on the more vulnerable members of society, including women and gender minorities. Slide. So recognizing that the same outcomes were likely to be reproduced during the COVID-19 pandemic, in early 2020, our team prepared to undertake a global gender analysis in order to provide real-time evidence to inform public health responses. So for the past year, we've been conducting a comparative case study of the effects of COVID-19 and government responses in several partner countries. Slide. In addition to documenting and evaluating the gendered impacts of the COVID-19 pandemic on our website, we have also collected a large number of relevant resources and communication outputs, working papers, statements, briefs, and we've produced tools. Slide. Including a well-received brief on how to create a gender-responsive pandemic plan. So this brief is a tool that can be used by policymakers, practitioners, and researchers to inform pandemic policies and activities. The contents of our brief fall under 6 main sections. We'll talk about data and priority areas in upcoming slides. In the brief, we discuss the process of addressing pandemic preparedness, response, and recovery. We discuss the need for multi-sectoral and multi-level partnerships that are diverse and representative. And we include a selection of related resources that provide detailed guidance and materials. The framework template at the end of the brief can be used to record activities and key indicators for each priority area at every stage of a pandemic. Slide. So what do we mean when we say a gender-responsive pandemic plan? Slide. A gender-responsive pandemic plan takes into consideration the intersectional needs of women, men, and gender minorities in planning, data collection, response, and recovery. This includes considering and addressing how women, men, and gender minorities experience differential primary short-term and secondary long-term social, economic, security, and health impacts. Slide. The secondary impacts vary somewhat across different countries and contexts, but in our brief, we outlined 6 priority areas that have proven problematic and important in past pandemics and during COVID-19. These areas all require special attention to protect populations' health and well-being, to safeguard economies, and to maintain progress made towards gender equality. During pandemics, including COVID-19, we've seen increased levels of gender-based violence across contexts. Women, girls, and LGBTQI people are more likely to encounter this. We've seen worse mental health outcomes at the same time that mental health services are interrupted in what is already a chronically underfunded sector in many countries. Reductions in essential sexual and reproductive health services, groups disproportionately disadvantaged by the economic fallout of pandemics, including women who are overrepresented in more adversely affected sectors, as well as increases in unpaid care work for women. We've also seen a lack of representation in local, national, and global health leadership positions. So as was mentioned before, although women are 70% of the global health and social workforce, they hold only 25% of senior roles. And girls, refugees, learners with disabilities, and students living in resource-poor or rural areas are more adversely affected by school closures. Slide. These secondary impacts are not only disruptive in the short term, they can come at a high cost, especially when they're compounded. So for example, reductions in sexual and reproductive health services may lead to increases in unplanned teen pregnancies, which may make it more difficult for adolescent girls to return to school. So when they're compounded, the ripple effects can have long-term consequences for individuals and communities. One of the things that we know in public health is that health is influenced by our biology as well as our social environments and the different facets of our identity. Gender is a major component of identity, and gender, along with race, age, and socioeconomic status, impact health outcomes, including vaccination. Slide. So gender responsive pandemic planning needs to apply to vaccination strategies as well. If we look at the percent of men and women who have received at least one dose of a COVID-19 vaccine across a subset of high, middle, and low-income countries, we can see that in some countries, men represent a majority, and in other countries, women do. Slide. So what are some of the factors that could explain the gender imbalances that we see in COVID-19 vaccination rates globally? Well, some groups had early access to vaccines. Age group demographics can explain some of why women had early access to vaccines in certain places. For example, in the US, senior citizens were one of the first groups to be eligible for the vaccine. Women tend to live longer than men, and in the US, they represent more than 55% of adults 65 and older. So more women were eligible to get the vaccine earlier. Occupation is a gendered variable. In many countries, certain essential groups like the health and social workforce, in which women comprise a global majority, also had a head start on vaccination. Gender norms and behaviors. In many countries, men are not only more likely to engage in risky behaviors like smoking, they're also less likely to engage in health-promoting behaviors and preventive care. With COVID-19, we saw this among men in certain contexts who were found to be less likely to wear masks and wash hands. Similarly, some men's hesitancy to get vaccinated may be explained by an aversion to being vulnerable associated with traditional masculinity. Conversely, women tend to be responsible for caregiving in families and households, which may make them more likely to engage in care seeking for themselves and others. Misinformation. One of the more common misconceptions about the COVID-19 vaccines is that they cause infertility in women. This may explain hesitancy among certain women. And it's also important to consider the social and political dynamics in which vaccines are delivered. In places where there is social or political unrest, women are often among the more vulnerable groups. For example, during the Ebola outbreak, 2018 to 2020 in the Democratic Republic of Congo, there are many reports of violence and sexual exploitation, including male healthcare workers trying to exchange health services, including vaccination, for sexual favors from women and girls. Slide. One example of what a failure to consider gender in health policy might look like in the context of COVID-19 is the vaccination passports many countries are considering distributing to help reopen economies. This document would define who is able to take part in public, social, and economic activities. Data about the safety of COVID-19 vaccines for pregnant women is limited, and in many countries, they're not yet eligible for the vaccine. So there would then be a subset of women unable to return to normal activities at the same rate as men or non-pregnant women. As children are also not yet universally eligible for the vaccine, their activities in public life would also be limited. And since women tend to spend a disproportionate amount of time on childcare, this could further limit their ability to participate in public life. So vaccination policies can't be gender neutral. Bringing a gender lens to different aspects of COVID-19 is necessary to protect against inequalities. We can also see from these varied examples that the impact of gender on vaccination is very context specific. That's why it's important to apply a gender lens when developing vaccination strategies. And when we talk about something being gender responsive, we're not just talking about women, and we're not just talking about gender. a gender lens also acknowledges the interplay of the combined aspects of social identity that influences people's experiences of discrimination and privilege. So we're also looking at other important dimensions such as age, race, ethnicity, and sexual orientation. Slide. So how do we apply a gender lens to vaccine strategies to improve uptake and access? I think one of the most important things is for vaccination strategies to be data-driven. Ethical and safe collection and analysis of intersectional disaggregated data is the basis for developing and implementing and evaluating an effective gender-responsive pandemic plan. This applies to COVID-19 vaccination strategies as well. Bridging the global gender data gap needs to be a priority if we are to mount a stronger gender-sensitive COVID-19 response. Epidemiological data disaggregated by social stratifiers will allow us to identify and prioritize populations at increased risk for infection, disease, and death. Disaggregated data can also give us a reliable basis for making difficult decisions about how to allocate limited supplies and resources. So an intersectional perspective can also help to prevent discrimination and improve equitable access and appropriate implementation. Gender-sensitive indicators can also help to monitor equal access to vaccines. Reliable and timely data should be used to monitor performance of vaccination programs. And in order for that information to be useful for decision-making, there needs to be a feedback loop to policymakers. And intersectional disaggregated data can also help public health practitioners to develop targeted vaccination communication. Slide. Earlier this year, the Gender Equality Working Group and the UNU Gender and Health Hub presented a guidance note and a checklist of priority actions that countries and stakeholders can take to ensure gender equality and equity in the planning, delivery, and monitoring of COVID-19 vaccine deployment. Recommendations include collaborating meaningfully with gender experts and community representatives, employing culturally sensitive and evidence-based messaging, and creating data systems that collect, report, and use sex-disaggregated vaccine outcomes in decision-making. Slide. How can pharmacy, the profession, and pharmacists contribute to this agenda? With this pandemic, there has been more discussion around gender and sex in clinical research. That should be the norm. We need to prioritize analysis of key sex and gender considerations around safety and efficacy in vaccine research, development, and delivery. Pharmacists are also trusted service providers in many communities, and they're uniquely positioned to provide accurate information to their communities that can help to counteract vaccine hesitancy and improve demand, especially in minority or disadvantaged communities. And we all need to advocate for the equitable distribution of COVID-19 vaccines in high, middle, and low income countries. As we've all seen over the past year and a half, what happens in other countries greatly impacts us all. We're living in a global world, and global health security depends on all of us having an opportunity to get vaccinated. Slide. You can also join our Gender Working Group. It's a platform to share resources and ideas and look for collaborations. We now have over 300 members from academia, civil society, multilateral organizations, and government from across the globe, all with an interest in gender and COVID-19. Anyone is welcome to join, and you can send a message through the website. Slide. Thank you.
Thank you, Erica, for your presentation. Thank you for sharing with us the importance of the gender lens in developing vaccination strategies and the importance of advocating. Now I'd like to introduce our third and final speaker, Sophia Segura, who is a PharmD Master in Pharmacology and Drug Management from the University of Costa Rica, currently studying the master's degree in social gerontology at the Ibero-American International University. She's a professor at the School of Medicine of the University of Costa Rica for more than 10 years, where she has directed several projects related to the responsible use of medicines in the elderly population and their caregivers. She's a coordinator of the Institutional Program for Adults and Older Children of the University of Costa Rica. And in addition, she has worked as a collaborator of the FIP with the documents Pharmacists Who Support Women in the Responsible Use of Medicines, Empowering Informal Caregivers and Give It a Shot, Expanding Immunization Coverage Through Pharmacists. She is a member of the Commission of Pharmaceutical Specialities, College of Pharmacists of Costa Rica, 2015 to present. So I'd like to introduce Sophia Segura, and we look forward to hearing your presentation.
Thank you, Carlene, and hello to everyone. First, I am very honored to share this session with such notable colleagues. I would also like to thank the opportunity to present a reality that is often invisible, and I mean informal caregivers in the context of vaccination. As you will see, most of my titles are questions, and this is not by chance, because when we talk about access to health, we must think about all those questions necessary to achieve gender equality. Next, please. Okay. If we want to talk about gender equity and equality, we have to define them first. Gender equity refers to the process of being fair to women and men. Meanwhile, gender equality requires that women and men enjoy socially valued goods, opportunity, resources, and rewards equally. Equity leads to equality. Therefore, a fundamental aspect of promoting gender equality is the empowerment of women, and why not empowerment of women in health. Next, please. To meet this objective, we must analyze the determinants of health, since they represent 30 to 55% of health outcomes. At this point, I want to ask you if, from your experience, have you seen inequities in any of the following points: income and social protection, education, unemployment and job insecurity, working life conditions, food insecurity, housing, basic amenities and the environment, early childhood development, social inclusion and non-discrimination, structural conflict, access to affordable health services of decent quality. From my experience with informal caregivers, I can tell you that yes, I have seen inequities in these determinants when we speak of women, and more specifically, when we speak about informal caregivers. This situation is present in different activities, such as vaccination. Next, please. As I said, my presentation is about informal caregivers. So I would like to start by defining what care is. Care refers to the provision of personal, face-to-face services to meet the physical and emotional needs that allow a person to function at a socially acceptable level of capability, comfort, and safety. Okay, now the next question is, who cares? The answer is simple: women. As can be seen in the graph to the right, the time spent per day in unpaid care is notably higher for women. From the feminist perspective, the sexual division of labor is a descriptive and analytical category, the result of power relations and the subordination of women, and serves to reveal the naturalization of feminine qualities of submission and care. This criticism has been part of feminist struggles, and the reflection on care is a theoretical and practical debate. In any case, It is a responsibility for states to seek recognition of care as the core of the development of human beings. Informal caregivers, mainly family members, are those who attend to the basic needs to maintain another person in conditions that ensure their health. This has social, economic, health, and cultural implications for the caregiver. Now, who are they taking care of? They take care of everyone: children, people in a condition of dependency, and the elderly people in a condition of dependency. This is extremely important because we are going through a phenomenon of population aging. That means that by 2050, approximately 16% of the population will be over 65 years old. Certainly, there is a great diversity of functional ability in this age group, and there are initiatives to promote healthy aging. Despite this, it is true that there will be a percentage of older people with different degrees of dependency. Given this scenario, I ask you again, who cares? Now, the answer should be that we all care because we are part of a whole, including pharmacists. Next, please. Some data indicate that 57 to 81% of caregivers of the elderly are women. And this study, published in 2020, talk about the risk for some conditions that affect the health of the caregivers of older people. And the data were extracted from a national representative population study on health and well-being in 6 low and middle income countries: Ghana, India, Mexico, Russia, and South Africa. And the results indicate that women were not only more likely than men to be informal caregivers, but that caregiving effects were more pronounced for female relative to male caregivers. Female caregivers were 1.86 times more likely to report severe depression and 1.45 times more likely to experience moderate difficulties in life tasks compared with female non-caregivers. These effects were not seen for men. Findings on the caregiver burden on depression and self-rated difficulties are consistent with previous evidence that shows high psychosocial and emotional costs of long-term caring on the well-being of caregivers. And at this point, you may ask, why are you talking a lot of informal caregivers and you are not talking specifically about vaccination? And I think that it is important to talk first about informal caregivers because I know that most of all have worked with them every day, but we don't realize that they have a strong and tough work to do every day, because it is in some countries, it is normal to see that. We have to recognize that this job is a burden mainly for women. Next, please. Okay. And what has happened with COVID-19? Well, Erika and Samira already talked a lot about the effects of COVID-19 on women. And I just want to say that epidemiological data shows a greater impact on men than women. And at least in the US, vaccinations rates are higher for women than men. However, it should be also be noted that the coronavirus outbreak exacerbates existing inequalities for women and girls in all areas, from health and the economy to security and social protection. Also, the increased demand for care work is deepening existing inequalities in the division of labor by gender. While it is true that the United Nations points out this inequity, it also recognized the leading role of women in care during the pandemic and advocates for their inclusion in pandemic responsive plans, including those related to vaccination. That's why in the next slide, next please. Okay. I wanted to bring you an FIP report of 2018 about the role of women in healthcare. And this report says that the role of women in healthcare can be outlining in the following roles: empower women in the role as informal caregivers. And at this point, I think that we should study a lot more and define much more the term empowerment. Also, communicate to women the need to be informed and support women's health literacy to enable them to influence others. Now, speaking about the role of informal caregivers in the development of pharmaceutical vaccination services, I want to say that these three functions can be translated in the context of vaccination as follows. First, increase vaccination rates directly and indirectly. Second, promote access to information on vaccines. Third, clarify misconceptions about vaccines. And fourth, improve the safety and healthy practices of the people served. Despite this incredible potential, I must point out that in Latin America, there is a lack of policies and actions to be carried out in several areas related to informal caregivers. For example, in vaccination, many of the informal caregivers do not have access to health services because they do an unpaid care and they are out of the system. And recently, with the vaccination against COVID-19, at the beginning of vaccination campaigns, many of our countries did not have the enough quantity of vaccines, so they made a stratification according to priority groups. And the informal caregivers were not included in any of these priority groups in Latin America. We have to know that the informal caregivers are synergistic with systems and formal health services, but unfortunately are a neglected group for public policy and health interventions. They face many challenges: lack of institutional and financial support, loss of job opportunities, overloading of tasks, often without proper training, and a great social and family pressure regarding their duties. So, in the next slide, next please, I want to conclude with one more question. What can be done? What can be done as pharmacists? And I have to say that it is not possible to achieve a goal on informal caregivers if their contribution, value, and support to our societies is not recognized. So the first step is to acknowledge them and make them visible through a strong advocacy. Globally, there is a need to drive transformative changes for equality by addressing the economics of paid and unpaid care. And as pharmacists, we must encourage gender equality to achieve a better health in our societies. Next, please. Regarding this last point, this slide shows the FIP development objectives involved with pharmaceutical services in vaccination. And I would like to conclude by saying that the full and real development of these services is not possible without gender equality. This must be transversal for the services, for the patients and users, and each of our communities. And here I want to finish with one last word that Erika already said, and is advocate. We can advocate in any area that we work, in community pharmacy, in hospital pharmacy, in the academy, in public policies, in every single work we do, we can advocate. And with this, I conclude my presentation. Thank you very much.
Thank you so much for that, Sophia. That was very enlightening indeed, and touching a very important point as why it's important to have gender equity with respect to vaccinations, but also the role of informal caregivers who are predominantly women. So thank you so much for that. So we're now going to move on to our question and answer session. So please do submit any questions that you may have to any of our panelists within the comments box on Zoom, or if you're watching via YouTube, then on YouTube, so that we can put these to our speakers. So I'm actually going to start out with the first question, and this question is for all three of our panelists. So if we can do it in speaker order. So first with Dr. Samira, and then Erica, and then Sophia. So our first question here is with respect to pharmacists. So I'm just pulling this question out here, if you can just bear with me. How can pharmacists contribute to better access to vaccinations? I know, Dr. Samira, you did touch on this, but maybe if we can hear everybody else's perspective more detailed to that, Dr. Samira, that would be great. So I'll start with Dr. Samira. How can pharmacists contribute to better access to vaccinations?
Yes, thank you very much for this interesting question, Nadia. As I already said, it's because pharmacists, for example, or working in private sector, like in Burkina Faso, we have a lot of pharmacies where people can go and buy their medicines, and I think it's everywhere in the world. We have private pharmacies. They can, for example, have information sessions or even posters, because, for example, in Africa, not everyone can read, can understand English, for example. They can have information session in local languages, or for example, posters in local language where they can inform population on COVID-19, ways to prevent the disease, including access to vaccination, where they can have access to vaccination. I personally have had a lot of questions from people who want to have the vaccine, but they don't know where they should go to get access to the vaccine. This is an example. They can also, for example, even organize. I see that in many high-income countries, they allow pharmacists as local health service provider to organize immunization sessions for their communities. This can be done by an initiative, but everywhere in the world, the group of pharmacists or the Federation of Pharmacists can decide that, okay, we are going to advocate for the possibility that at local level, pharmacists can organize immunization campaign, and because they are the one mostly in touch with the population usually. So there are a lot of examples that of activities that it can do, and that data are really important in this COVID-19 monitoring, because they see the community, they live in communities, they work in communities from where they can report data on accessibility, on side effects related to vaccines, and so on. They can also, for example, help local services where vaccine is provided. All these are examples that can be of work that can be done by pharmacists to contribute to access to vaccination and testing, and all response strategies developed to fight against COVID-19. Thank you.
Thank you for those great examples, Dr. Samira. Same question to you, Erica. How can pharmacists contribute to better access to vaccinations?
I think one of the more important things that pharmacists can do is work in their communities, especially minority and disadvantaged communities, where vaccine hesitancy can be a real problem. And that can be for all sorts of reasons, ranging from structural barriers to misinformation. But sometimes it's also, unfortunately, because of histories that these communities have with medical establishments, and there's a lack of trust in anything that's coming from the government and that's being produced so fast. So pharmacists who are based in local communities, they already have an inroads with these communities, and they might be able to help facilitate collaborations with other trusted community members, whether that's churches or teachers. And they could also help to do health education in their communities.
Great. Thank you. So I think there's a theme emerging here with respect to working with disadvantaged communities. So thank you for that, Erica. Same question for you, Sophia. How can pharmacists contribute to better access to vaccinations?
Well, I think that the pharmacists can make a strong advocacy, a local and regional advocacy. And I think that we have to think beyond COVID-19 vaccination. We have to remember that vaccination includes another diseases, and that vaccination is a process that goes with the life, right? And specifically pharmacists in a local community, they can work as guiding the women in information. They can make campaigns, they can make education, they can talk sometimes, and the people just want to talk and know a little more about health and about diseases and about how they feel. And I think that this is important. Maybe you can think that are only 10 or 15 minutes talking to someone, but that conversation can make a greater impact in the life of one person or one family. Thank you very much.
Great, thank you.
Thank you. I might start by asking the next question, and we'll go in the same order if that's okay. So I wanted to ask, from your observations or from your experiences, have you seen any good examples of vaccine equity? So you can take a minute to think about it. But yeah, we can start with you, Dr. Samaratu.
When we talk about vaccine equity, we are not just looking at gender. We should not just look at gender. It's equity at the broader level. It's equity for those working, those living in remote areas. It's equity for disabled populations. Equity is a broader aspect to be considered. So honestly, I don't have like a single example where I say, okay, this is a vaccine equity. But in some high-income countries, we tend to have free access to vaccine, but it's not sure that the way like transportation is for provided, for example, for those limited access to transportation to go there and have a vaccine, for example. We have a lot of examples of countries. Okay, it's free. Everyone should be vaccinated. There are a lot of areas that you can get access to vaccines, but we are not sure that everyone have even individual choices to go to have vaccines. We know that if, for example, in Africa, even if you provide free services to everyone, some women, for example, can be forbidden by their husbands to go to have access to this vaccine. But nobody will know that she want to have a vaccine, but she is not allowed to because her husband forbid her to go to have the vaccine. This is an internal aspect that external community or external population policymaker won't know. They will say, okay, it's free. It's everyone should go. Everyone have access. Even if you provide transportation, even if you pay for her transportation, she won't go. You will ask yourself, oh, she's not interested or she's hesitant. Maybe she has over limited that forbid from going to vaccination. So I wouldn't say there is a perfect example of equity. Honestly, I don't have like an example of equity in access, because when we talk about equity, we're not just looking at gender or anything like that.
Thank you.
Thank you.
Thank you for sharing. Erica, do you have any thoughts on the question as well?
I would agree with Samatu, but I think more than a specific example of vaccine equity, what I've seen during this pandemic is a lot of efforts to achieve vaccine equity. And, that's come from a lot of different directions. I think funding is going to be one of the most important things, in particular for getting the vaccine distributed globally across high, middle, and low income countries. And there has been a lot of funding that's gone towards that and efforts, but we're not there yet. And there's going to need to be a shift in thinking where people realize that global health security, they can't just be focused on their own individual countries. It really has to happen at the global level in order for us to make it out of this pandemic.
Thank you, Erica. Sophia, can I have your thoughts on the question?
Well, I have to say that I do not have a perfect example, just like Samira said. And I want to rescue some words of Samira when she said that you can give all the services, but maybe the people would decide not to go. And here I just want to say that if you want to have equity, you have to work access in the same line that you are working, education and information. Because if you provide access, but you do not educate and inform the people, they will not understand the meaning of this access. And I think that these two words have to be together in order to get this equity.
Thank you. Thank you, Sophia. So I'll pass on to Nadia now, who's been having a look at the chat box. You maybe have some extra questions to ask our speakers.
Yes, we do have a few actually, and some comments as well. So first question here, how can pharmacists and women co-create information on vaccination to support women in local communities? So we have been talking about engaging local communities, and that was a theme that came up with respect to pharmacists sort of supporting the whole vaccination drive. So do we have any thoughts on how we can co-create information with women? Dr. Samira, would you like to shed some light on that?
Yes, absolutely. Yeah, how? By as we know as Sophia said, advocacy, and Sophia and Erica touched on advocacy. We can together organize or join group of advocates who are working toward vaccine equity or COVID-19 response equity in order to implement information strategies. Like, for example, vaccines for pregnant women. It's so controversial. So even within healthcare provided, we have controversies. We are not sure if we can vaccinate pregnant women. And for example, in Africa, we know that at the beginning of vaccination, some countries were saying that they won't recognize those vaccines coming from Africa. Look, if you have received vaccine from Africa, you won't be recognized. So people started to think about, okay, maybe the vaccine coming in Africa is not good. It's not the right vaccine. These are all misinformation that a group, not only gender-based group, like not only female, we can like set information strategy, right information strategy to reassure all population, to emphasize and to advocate for vaccine uptake, for example. I think it's at this time, it's not about creating a group or like creating a movement saying we are a movement of women, we want to advocate for equity. It's about joining movements that are already organized, that exist, reinforcing them and helping them provide right information. And even right information, we tend to focus information on social media, forgetting that at local level, many women don't have access to local media. We need to find channels where we can reach these women through word of mouth, for example, through like a group of women at local level working to challenge power or even to inform their community and so on. So there are different strategies, and I think coming together, we need to think a lot and to put like the priority to the need to everyone. And I'm not for a strategy where we only talk about women. We should talk about equity and gender equity in general, because it's not only about women, it's about all of us. We are all together on this.
Absolutely, absolutely. Sophia or Erica, would you like to add anything on that with respect to how we can co-create information on vaccination with pharmacists and women?
I would just add that I think it also depends on what level you want to target. So partnerships can be created at the national level, at the local level, at the international level. And depending on what level you're going to have a different impact. So a federal level partnership might have a wider impact. Local level partnerships with civil society groups might be better for making inroads in vaccine hesitant communities. So I think that's one of the things to think about. And then also pursuing diverse partnerships, particularly at the community level. I think looking at community-based organizations, community leaders, traditional leaders who may already be providing important services in their communities, forging partnerships with them and amplifying the work that they're already doing could be a more effective strategy. And I would also say that we should look at...
Sorry, carry on, sorry.
I was just going to say we should also look at informal communication methods as well.
And then that's a really important point you make there, Erica, because I think it also depends on the way the country is run. Sometimes a bottom upward approach is good. Sometimes a top downward approach is good. So I think it depends on how the country runs itself, if you know what I'm saying, with respect to the governments. Sophia, would you like to add anything there?
Yeah, I just want to add that according to what Samira and Erica said, that sometimes, for example, the community pharmacists doesn't know how to make a group or something like that, because they think that they are going to need a project or something strong and big enough as to make something significant. And I just want to say that we have to start with what we have and how we can. So you can start simple and start with what you have, with the networks that you have, with the people that you have. And maybe it could be a chat on WhatsApp, or maybe a meeting, a small meeting with the people, but start with something, because advocacy must be transversal to all the areas of pharmacy.
I love that hashtag, just do it. So if you feel that you can do something within your pharmacy, you know, start at home first, and then you can move outwards. I think that's really, really good advice. There's a comment here with respect to something that you mentioned, Dr. Samira, that people are surprised that still in the 21st century, husbands can still forbid their wives from vaccination. Any comments? Any of the panelists can comment here.
Yes, this, but I don't really know how the mentality, the way the society is organized is working in Africa. I have an example, like, it's not just vaccine, everything, like it's in some countries and in some communities, the women belong to the husband. After you get married, you are not, even your family can defend you. Even your family, you are your husband thing. I don't know, I will say thing, because he decide on everything. And for example, we were doing serological testing for COVID-19. Seroprevalence, a study on seroprevalence for COVID-19. And we went to a house where we found the women, because she's a household, she doesn't have a work, she stays at home. And we asked her if we can have a seroprevalence, we can do just a blood test to test if she have had access to, if she has been contaminated by COVID-19. She said, yes, yeah, I would like to, and I will give you my blood, you can test it, because her husband were away and went to work. We collected the blood, and the evening we received a call that the women have been, her husband told her to leave the house, because she agreed to participate on to our study without asking him to say, yes, I want my wife to participate in the study. And her husband told her, go back to your parents, because you are deciding by yourself now. So yeah, I don't want to stay with you again. And we were obliged to use like community leaders and even high level, even I think we went to the mayor and the Ministry of Health to have a talk with the husband, just to reassure him that no, it's not something that hurt your family or hurt your husband. It's just to see if she have had the COVID-19 previously. This is just an example on how far and how constrained women can be in the choice. Everything she had to do, she want to do, she has to ask her husband approval before doing it. And this is still real in Burkina Faso, in Ouagadougou, the capital city of Burkina Faso, not like in a village or a rural area. Yeah. So don't be surprised, it's the truth.
And we have similar stories in the South Asian subcontinent as well. So still in 2021, we have the husband controlling the entire household and women having to ask permission even before they can even leave the house. So this is a widespread issue for sure. So thank you for that. We've got a comment here, and it's a very good comment. From Tracy, who says it always helps to engage the key opinion players in a given community, for example, religious leaders, male leaders, before initiating any advocacy intervention. Once they're convinced or by the necessity for promoting equality, then it becomes much easier to promote the needed change, whether vaccine uptake or any other intervention. And that's a great comment. And that's something that I've definitely seen on the ground as well, that when you engage key opinion players, and especially when it comes to men, and have them on side, it just makes driving the gender equality, gender equity agenda forward that so much more easier. Any other comments from our speakers? Okay, that's great.
I have an example in Burkina Faso, and in West Africa there is a project called SEED. I don't have the name in English, but they call it husband school. And to change the community, they empower husband, and they sensitize husband and explain them why you need to take care of your wife when she's pregnant, why you need to be involved in taking care of your children as well, because usually in Africa, in Burkina Faso, I think in many other countries, it's for women to take care of the family, to do everything, take care of children or older member of the family. So we had an example of a project where to change this, community leaders and community because we have religious community leaders, we have cultural community leaders, and we have also leaders of local associations. Through them, they change the community in a way that men feel empowered, but you are more empowered when you're women. Also, you take care of your family and your children and your wife, and you can even go to the maternity with your wife to have like prenatal care and so on. So this is an example of an intervention where to change the health outcome, and this is to change health outcome like pregnancy outcome, for example, because they know that sometimes women can be hesitant to go to prenatal care because she doesn't have like money to go there, but she doesn't have mobility access to mobility service to go there. But empowering her husband to be part of the pregnancy, to take care of her, is also enabling a woman and facilitating access to healthcare services to the women as well. So this is an example of the way we can change health outcome. This is not related to COVID-19, but it's an example of the way to change community health outcome. We can use different strategy at community level to empower people in general.
That's great. And that touches on also what Sophia was saying with respect to women being the informal, women predominantly being the informal caregivers. So that wraps up our question and Q&A session up quite nicely there. So thank you for your questions. I think we'll just we've just got a few more slides to go through before we wrap up the webinar. Over to you, Carleen.
Thank you. Okay, so just a discussion on the program that you've been part of. So the FIP Transforming Vaccination Regionally and Globally 2020, recapping the key outcomes. So it's the first FIP digital transformation outcome-based online program. It's underpinned by the FIP development goals and resulted in the global FIP commitment to action on vaccination in pharmacies and FIP transforming vaccination collection. So the Transforming Vaccination 2021, that's 12 events over 2 series. Series 1, towards equity in vaccinations globally, and Series 2, sustainability in vaccinations regionally and nationally.
The key outcomes for the Transforming Vaccination 2021 program, 12 digital events, which include 6 regional roundtables and a leadership summit, FIP global commitment to accelerate equity, access and sustainability of vaccinations, and a special policy collection. Our next upcoming event is event 1.4, Health Illiteracy and Vaccine Misinformation as Determinants for Equity, Developing Policies to Establish Access to Quality Information in an Equitable Way. And this will be on the 26th of August, 2021 at 1 p.m. CST.
So please join the next events, and to register you can scan the QR code that's on the screen, or you can visit the events.fip.org or transformingvaccination.fip.org. So check all future FIP digital events here on events.fip.org.
And just to remind everyone that World Pharmacist Day is coming up, and we'd like you to join the hashtag WBDPD 2021, join the campaign. The COVID-19 pandemic highlighted how we're all connected across borders and has also emphasized the value of solidarity amongst the pharmacy profession. FIP invites you to make sure your country is represented by showing your support on World Pharmacist Day 2021 Champions Wall. So it just takes a few simple steps for you to create your graphic and add your voice. The first of which is if you click on this, when you actually have access to the slides, you can actually have a look there and you can have access to it. And our hope is that colleagues in all countries and all states in the world take part in advocating our superb, amazing profession. And it's now in its 11th year, World Pharmacist Day, and it's an opportunity for our profession to make our vital role in improving health known in every corner of the world. So we really, really hope that you join in on our World Pharmacist Day campaign. So with that, I'd once again like to thank our amazing panelists, Dr. Samira, Sophia, and Erica, for their insightful presentation and discussions and opinions with respect to vaccine inequities. Thank you all so much for joining. We all hope you found this session very useful and informative. Have a good day, and we will see you in the next webinar. Thank you so much. From me and Carleen, thank you.